can you tell us just a little bit about what it's like to set up a program for someone who maybe doesn't have that in their place?
Yeah, this is a question I get asked a lot, and honestly is probably the most important part of cancer rehabilitation, because we need to have more programs. Patients are desperate for access, and every location is different. And so this isn't a one size fits all thing. When I started, my chair said, okay, we've tried cancer rehab a few times at Michigan. You can try it. If not, we have general spine patients you can see, and I was going to do general inpatient as well. I said, sure. Where the deal was, as I built up the cancer clinic, I would do less spine clinics. There was one physical therapist and two occupational therapists who specialize in lymphedema, and they're wonderful and invaluable. But the good news is that within a year and a half, I was out of all my spine clinics because the cancer rehabilitation clinics were so full. Not just because of me, but because of patient volume and word, we started hiring lots of therapists who specialize in this, including lymphedema, and I think we're up to 7 or 8 now. And the key to this, and what can challenge some, but I think also helps others, is that you really have to sell the value of physiatry, especially physiatry, to the stakeholders, and that means medical oncologists, surgeons, radiation oncologists, and when I say surgeons, I mean ortho, plastic surgery, general surgery, breast surgery, everyone on down, and somewhat to administrators. The thing I consistently hear, I would say 9 out of 10 times when people start a program, is that they are welcomed with open arms, and the reception is, thank goodness you're here. Where have you been all this time? There's not an oncologist out there, or if they are, they're alone. There's not one out there that says, no, I don't think my patients need to function better. I think we got this. There are some, I think people maybe nearing retirement who might say, well, we have a physical therapist. What do we need you for? But that's where I think you have to really reflect on what physiatry is. Forget cancer physiatry. Forget brain injury medicine, all that. Like, what value do we bring? Okay. And so you have to distinguish yourself from physical therapy. I'm not a physical therapist. They do things I don't know how to do, and I do things they don't know how to do. But what we can do is we can manage symptoms. We can improve function. Don't say quality of life. Everyone hates quality of life. It means nothing, right? Don't say quality of life. Say I can improve their function, or you can speak their language and say performance status. I like to give examples that are really easy to wrap their head around. I don't like to be vague and say, we can work on people getting stronger. What does that mean, right? Even though we all know, the rehab people listening to this know what that means. That's really nebulous. So I might give examples of, this is a procedure I can do for post-mastectomy pain. This is something we can do for aromatase inhibitor arthralgias. This is how I assess somebody for radiation fibrosis syndrome. I can offload those patients from you. I can order and interpret diagnostic tests, including MRIs, EMGs, all that, which are something that physical therapists or occupational therapists or whoever can't. I can prescribe medications, and I can coordinate all this for you. And they say, thank goodness. But once you get them in the door for the post-mastectomy pain or whatever, I found that it was really quick and easy to get the word out, as far as I could also diagnose and treat mild cognitive impairment, or that deconditioning or peripheral neuropathy that, before I was here, they just assumed had to go to neurology, But when you can talk about the functional implications of some of these things, it's a lot easy. The one challenge is that it's a lot of work, and you have to sort of water your garden, if that makes sense. So when I started, I did a road show. I went to breast cancer, I went to palliative care, I went to plastic surgery, ortho, blah, blah, blah. I showed my face a lot. I gave talks. I gave grand rounds. I showed up to their tumor boards, at least the ones that were maybe relevant, like sarcoma or brain tumor. Those are the ones that are, really, there's a, for one, having a physiatrist in the room might change the decision making, but there's functional talk of the treatment there, as opposed to, pancreatic or something. And I made it known that I wanted to be one of the team, and they were happy to have me. You're not going to get anywhere I don't think. If you are very general or you get up there and say, hey, you should send me your patients when, they think that everything's being treated okay as is with status quo. And if you run into trouble, there's national guidelines that, have been written that say you need rehabilitation. There's some that specifically recommend PM&R to be involved in XYZ, and that really helps. We're trying to get more physiatrists on these guideline writing committees, and we've gotten some, and to sort of reduce the threshold that you have to clear, so to speak, to get the referrals. But I think it really takes somebody to put themselves out there, communicate well, make a PowerPoint that doesn't have 50 words on a slide, right? Like basic stuff there's nothing special about cancer rehab, but you really have to dig deep and think about how you're different than therapists and what value you bring and why this patient should see a seventh or eighth doctor and why it's worth their time.
Yeah, great points. I think, especially because I see a lot of doctors who basically come by and say, send me your patients. But, tell them what you have to offer their patients and how you're going to take some of the burden off the physicians, and overall provide better care for those patients.
Yeah, it's been like advocacy, 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 right? It's like advocacy for your patients, yourself, but also for what you're doing is for the entire specialty, not just cancer rehab, but the whole world of rehab. So that's really amazing. Thank you for all the hard work you've put in.